Hi, Helena.
Hi, Adam.
And hi to all of our listeners. We've got a fantastic episode for you today. But before we introduce our first guest, Helena, why don't you tell us all about yourself?
My name is Helena Dix, aka Queen of the High Notes, but my mother also calls me other things. I am an international opera singer who loves globetrotting around the world and singing high notes and causing mischief. When I'm not on the stage, I love to cook, to laugh, walking my dog, hanging out with all my wonderful friends.
And my name is Adam Miller. I'm a former opera singer turned producer, writer and director. And Helena, you and I have had the great pleasure of working together in all sorts of capacities over the years. Now, why don't you tell us who our guest is today?
Today on the podcast, we are joined by Declan Costello, one of the UK's leading ENT surgeons and a true authority on the human voice. Unusually, he started out not in medicine, but as a choral scholar at Cambridge, studying music before going on to train as a doctor. So he understands the voice from both sides of the stage. He's become something of a legend in our operatic world, trusted by elite singers to diagnose and treat some of the most delicate and high-stake vocal problems. Alongside his clinical work, he's a past president of the British Laryngological Association, a published author, and even contributed to Grey's Anatomy. Put simply, if your voice is your livelihood, he's the person you want in your corner.
That's right. And as we pick up the conversation with Declan, we begin with a chat about how to pronounce your name, Helena.
We met in person, I don't think, Helena, have we? Your name is pronounced Helena, right?
It is, yeah.
Helena.
That's it. I've been called far worse, Declan, so don't worry about it. You know, it's fine. It's fine. Depends who you speak to.
We had a couple of guests on, a fair few weeks ago now, and one of them was calling Helena the whole way. And then one of the other guests actually told a story of a time that people had got her name wrong and Helena called them out in front of it. And you can hear him go, oh, I might fix how I'm pronouncing that now.
Although it's not as bad as the time that I, when I first moved to London and I was at the Academy, we did a Messiah with Chan Rochford, Julia Riley, Robert Anderson and myself. And we went down and, you know, a lot of those oratorio gigs where people will host you in between the rehearsal and the show.
Right.
These lovely people in this like little town. So we all go down. We don't know each other that well. And we're sitting around and they've put on this like dinner for us before we got into the oratorio, into the performance, I should say. But they were had slight amounts of dementia, so they were getting the names wrong. But it was really funny because they were eyeballing us, like they'd eyeball me and they'd go, so Chan, you know, like it wasn't even the female versus male names. Like
Brilliant.
One of them eyeballed me and said, so Chan, you know, have you been in the country long? And Chan went to kind of answer, but then realized, you know, they were eyeballing me, and it just became this kind of comedy of who are they speaking to versus who are they looking at versus, you know.
We can imagine Declan isn't the commonest name in the world. I'm quite often called Decland, as in the land of Dec.
There you go.
But there's an advantage to having a fairly unusual name in the sense that if somebody Googles you, you're one of the first hits that comes through, which is quite useful at times.
And also, you are like, you know, the consultant to everyone I know, your name is there. You know, every time anyone talks about, you know, vocal stuff and ENTs and laryngologists and like all the thing, it is always your name, always. It's
that's really nice to hear. Yeah, I mean, there's a relatively small pool of us doing what I do.
But you're a rock star. You're still a rock star in the industry.
I'll take that. I'll take that. But I think the other thing is that the singers have got much more savvy about who they go to see.
Sure.
You know, there was a time 20, 30 years ago when people would have walked up and down Harley Street or the equivalent of Harley Street in Sydney, and they would have just chosen the shiniest brass pluck they could see and go in there. Whereas people, I think there's word of mouth goes round.
Sure.
And people know that there's a pool of people who do quite a lot of this laryngology thing that I do.
So do you want to tell us then, actually, Declan, what you do, what this pool of people do?
Yeah, so I'm a laryngologist. I am an ear, nose and throat surgeon and I have a specific interest in voices. Over the years, medicine has become increasingly specialised and then subspecialised and sub-subspecialised. And to the extent that there are certain ear surgeons who do only about 2 or 3 particular operations, and within the world of voice, there are people who do certain aspects of voice, but my particular interest is in singers. So I do look after ear and nose problems, but I spend the vast majority of my time looking after throat problems, and within that, a lot of singers.
Wow. Oh, that's amazing.
We're a specialised beast, aren't we, to be fair?
Yeah, you are a specialised beast. And I think, we may come on to this, but part of the reason I'm doing what I do is because of my own background as a singer. So I sort of understand it from the other side, as it were.
Yeah. So tell us about that. Tell us about that journey was it a journey from singer to surgeon, or were they simultaneous? How did that happen?
Well, at school, I was doing A-levels that looked like I might be going in towards a career in medicine. Both my parents are medics, but actually a singing teacher took me to one side and my singing started getting better at that stage, and it looked like I might be able to do a choral scholarship. And also at that time, a tutor sat me down and just made me think properly about whether I wanted to do medicine or whether I was just kind of meandering into it by default. And at that time, I was enjoying the music more. I couldn't do a choral scholarship and study medicine at the same time because they both take up too much time. So I ditched the idea of medicine at that stage. But then halfway through the music degree, so I completed the 3 years of music, but halfway through the music degree, decided I wanted to study medicine after all. So went back and having done 3 years of music, I did 5 years of studying medicine and then worked through medical school. And then after medical school, did a variety of junior doctor, resident doctor jobs. And with it, I did a bit of plastic surgery, a bit of orthopedics and this and that. And I really enjoyed ENT. And then within ENT, doing stuff on voices seemed like the obvious thing.
Did you make the change because you found at all the singers' parties that when everyone was sitting around just talking about their voices all the time, it annoyed you, and actually what you'd rather do is get everyone to like stick their tongues out and have a look down and
have a proper look. Yeah, well, I do, as you can imagine, I do get quite a lot of questions when I'm at sort of social things. People by and large are quite good about not kind of nabbing me in quiet moments, but
and being like, sorry, excuse
I think
me,
not least because singers, and again we may talk about this in a second, but singers are quite sensitive about the fact that they may have problems with their voices and don't. If I'm in a rehearsal or in a social thing or whatever else, people don't particularly want to be that guy who comes up to me and says, look, I've been having problems with my passaggio for the last few months, because then everybody else goes, oh, right, okay, George is having problems with his passaggio.
Right, yeah, pass the turkey, yeah.
Right,
yeah.
Well, and that sort of taboo, I think, about vocal problems is very real. So, and it's something, again, we can maybe chat a bit about that.
Well, that's right, because of course, the last thing a singer wants is anybody whispering about to say, such and such went to see, a laryngologist, or they've got a bit of an issue that's going, that's literally the last.
And it's a great shame, because there's not. I mean, it's getting better than it was. I think there was a time a number of years ago when people just absolutely would lock this stuff down and they would never talk about it to anybody. Yep. But there's a number of singers who have talked about their vocal problems over the years. And I think, if I've operated on someone and things, and people are back on stage and they're happy, people will quite often post nice things on social media to say, look, I'm back on track. So there's much less in the way of silence and keeping a lid on things than there used to be. But people are still nervous. And I think there's a concern about appearing vulnerable. There's a concern about, if this particular opera company know that I've had problems, will they hire me for the next contract or that sort of thing? So I can understand where the anxiety comes from.
And it's about knowledge too, isn't it? Like, for instance, if you were, say, working with an opera company or you had a contract with them for the next year, I would assume, I might be completely wrong, I'm a soprano, so I often am, of course, but in saying that the management for the company would probably not have a lot of knowledge about the voice and about, the kind of physiological things. So if they heard that such and such had a bit of a problem, they wouldn't necessarily understand that might be a problem that's easily to get over or and so assumptions start to be made, don't they? And Yeah.
Yeah.
I wonder whether or not it would be helpful. I mean, I've said this actually before, and Adam and I interviewed Melissa, who runs the Lindemann program over at the Metropolitan Opera and does all those things. And she was talking about all the different aspects that they have for their young artists, including vocal health and understanding of that, which I think is amazing. And actually, look, obviously I went to college a long time ago and I was at the Royal Academy and all that kind of stuff, but it would have loved them to get someone like you in to talk about, various vocal health things and great good things as well, not just the negative things, but, the things to be doing in a positive.
Yeah, I think there are programs like that. And I think some of the conservatoires are doing that now. I think they do have an ENT surgeon at the Royal Academy who goes in. I do sessions for groups like Genesis 16 and university and college choirs and that sort of thing, just about vocal anatomy, about vocal health, how to look after your voice, what to do if things aren't going so well, just taking some of the stigma out of it and taking some of the fear out of it as well. Because I think there's a worry that if you have a problem with your voice, then that could be a kind of career-ending thing, and that then leads into an ongoing anxiety and a stress about going to see somebody like me to have your larynx examined. Is this going to be curtains for me? That the problem then is that leads into a vicious cycle of tension and stress that starts to feed into the problem. If people have a problem for a few weeks and think I just need to get this looked at, and they come and see me, have an examination of the larynx, and if everything's fundamentally fine, great, you can park that problem quite quickly and go back to the technical stuff. But actually, if you leave it for months and months and months, it festers, and psychologically you get yourself in a tangle, and then physically you get yourself in a tangle with muscular tension. So I think nipping these things in the bud can be really, really helpful. Just while I remember, there's another thing I think about people being worried about the discomfort of having the larynx examined. It's really, having your vocal cords looked at is really not very difficult, not particularly uncomfortable. It's a darn sight better now than it was 25 years ago, because we just use a little endoscope that goes in the nose. Previously, we'd have had rigid scopes sitting on the tongue and all the rest of it. But now it's very, very easy to do. Sorry, you were going to say, Helena.
Yeah, I was just going to say, Adam, I think when we had a speech on, we had Samantha Uron on, and I don't know, Adam, whether you recall whether it was her that said it or someone else that said it on the podcast recently. They said a really great idea for singers is to go and have a scope when you're in great health.
When you're healthy.
When you're in, and I thought, oh my God, I can't believe that I'm old, and I'd never thought of that, like that I'd never actually considered going and doing it, because it's so interesting, like fascinating.
And getting that baseline,
Very much. It's very interesting. It's destigmatizing, and it takes out the fear that if ever you needed to have it done, it's actually really not so bad. It's extremely useful for me to be able to have something to compare with down the line. Yeah. Actually, the Royal Opera House send all of the Yetta Parker young artists to me when they start for a kind of baseline examination,
right?
Which is super, super helpful. Yeah,
that's amazing. And so for our listeners who wouldn't have a clue what it looks like, tell us what a healthy scope would look like in basic terms for people to know.
So what we're talking about is the vocal folds, the vocal cords, which are two white structures that look like strips. As you look down, they look like sort of strips that meet in a V, and the vocal cords, so vocal cords and vocal folds are basically interchangeable terms. They're called vocal folds, actually, because as you look at the tube of the airway, they're just a sort of infolding of the airway. So vocal folds is probably slightly more accurate. So they should look at a kind of pearly white colour. They should not have too much in the way of sticky mucus on them. They should have straight edges. So this V, the straight lines of the V should be absolutely dead straight as a ruler. And the most common thing I would see in terms of abnormalities would be little lumps and bumps and protrusions on the inner edges of those straight lines. Mm-hmm. Sometimes I'll see some sort of redness in this. And then when I'm getting a patient to use their voice, that when they're being examined, I will initially just have them breathing very quietly, and I get the scope, having gone through the nose, I get the scope to a few millimeters above the vocal cord so I can get really, really close in and check the surfaces. And then I'll come back and get them to give me a sustained E, and then do some pitch glides and various other things just to examine the different aspects of how the voice works. One of the key things in terms of the examination technique that I use and that should be used for any singer is called stroboscopy. And stroboscopy is a technique whereby as the vocal cords come together, when they're vibrating, they're actually vibrating several hundred times a second, but stroboscopy gives you the illusion of slow motion. So it looks as if they're moving just it looks as if they're vibrating just 1 or 2 times a second. And that's really helpful because it gives me information about the pliability and the suppleness of the vocal cords. And for any singer needing to see an ENT surgeon, needing to see a laryngologist, stroboscopy is absolutely critical.
I remember having that done the first time. It was fascinating to see. Absolutely amazing.
Yeah, absolutely.
It's good. And singers are, they're universally absolutely fascinated by being able to see their own larynxes, but also they're tending to hang on to, is that a musical instrument?
I don't know,
Helena?
Or are you strangling a cat?
Yeah,
I'm just not sure.
It's children playing outside. How dare they have fun and play outside on the streets? There's all kinds of.
Oh, you've got to go onto the porch and be like, "Get off my porch! Get off my property!"
The other day I was teaching because my studio's at the front of the house, and one of the kids threw his football into my front yard, and I could hear them because I was doing my singing practice, and I could hear the father go, "Oh well, that's it. You've lost your ball now, mate. You're going to have to go and because it went over the fence." And he's like, "What do you mean, Dad?" And he's like, "I saw her. She did not look impressed with us playing because they several times in front of the yard." So I'd opened the door and I'd given that kind of slightly older woman looking disapproving, like as if to say, "Can you stop?" Because I was trying to record something at the time. I wasn't rude. I was just letting them know I was there, And the dad's like, "Oh, that's it. She was scowling. It's going to go now. The ball's going to go now." And he's like, "Okay, I'm going to go and I'm going to ask." And just at the door, and he's like, can I please have my ball? And I'm like, yeah, of course, no problem. And then I toddle off and I hear the dad go, "Oh, that was much easier than I thought. She didn't look impressed before."
Yes, you can, but I need 3 scales right now.
I definitely think there's a clown and a hooter or something out there, yeah, for sure.
Brilliant.
Just in the sense of now that you said about what a good scan should look like, and what a good scope should look like. When this is maybe a silly question, but I'm interested because one of my colleagues and I were having this discussion the other day about male versus female chords and also different voice type, the differences in voice type. So do you see a big difference for our listeners to know that in the voice types?
So the simple answer is just if I were looking at scopes on mute and not able to hear the recording of the voice at all, it's very, very difficult to discern one voice from another.
Okay.
Partly because, vocal cords are of different sizes and different configurations and different shapes and things, but when we look down with the endoscope, there's no ruler, there's no measure of how big one person's set of vocal folds is compared to another. So it's actually really difficult to tell. I guess in general, male vocal folds are thicker, but in terms of the length of the vocal folds, which is different between the sexes, but in terms of length of the vocal folds, you can't really tell that from looking with the endoscope because there's no way to measure it.
Okay, so there's no distinct difference between.
And in terms of different voice types, I sometimes have people contacting me to say, "I'd like you to let me know whether I'm, a high baritone or a low tenor just by looking with the scope." And I think, well,
oh wow.
That's not going to happen. There are certain things I can tell, but that sort of minutiae that's not really my
Oh, that's
role.
interesting because I certainly have heard people talk about the thickness of the cords being relative to voice type. So that's interesting myth to.
I think there's a danger, isn't there, of over medicalizing and over scientificizing, not a word, over scientificizing the whole process. And people,
we're going to keep that.
People thinking, what I don't want for singers when they come to see me is to hang on to the voice as a kind of mechanical, biological, physical process. Because yes, I need to look at the vocal folds and make sure that everything's okay. But actually, fundamentally, this is an artistic endeavor, a thing about engaging emotion and conveying words and meaning. And if people get too fixed and hung up on the physicality of the voice and tweaking this muscle and holding that muscle, and then you actually start to lose the sense of why you're doing it in the first place. There are some people who like to come to see me every 6 months or a year or so for checkups, and I, in principle, that's fine, and I'm very happy to see them. But I don't want people to get hung up on the sort of physical thing, because
Sure.
ultimately they need to be able to speak to a singing teacher. And why did I get onto that? I got onto that because I think this thing about looking at the larynx and determining whether somebody's voice is one type or another.
Gotcha.
I don't think that's for me. I think that's for the ears of an experienced singing teacher and for the singer themselves to work
of course.
through. And it's not for me to look and say, well, actually, no, I don't think you should be doing that. I think you should be doing something
You're
else.
not a tenor.
Yeah. Well, no,
Yeah.
I know. So that would really spook them, I think.
So how do you kind of resolve that for yourself as a singer, like as a singer and a mechanic? How does that play in your head?
I think what I tend to say to patients is that what I can do is to establish whether there is any problem with the vocal cords. Have you caused yourself an injury? Are there any bleeds or polyps or what have you? If there are kind of mechanical obvious muscular tension issues, then we can start to address those and maybe think about vocal coaching or singing teaching. But I try to avoid people getting too stuck on the sort of physical processes.
You know, I am not too shy to tell you, and I feel slightly ashamed in saying this, but I only went to see someone to have a scope done for the very first time ever in my career last year. And, you know, everyone was like, what?
You've obviously been very lucky. That's good.
What, you've
That's
never
great.
been
Yeah.
before? And I was like, oh, no. I will say that in general, I'm very fortunate to say that I'm not a singer who psychs themselves out very frequently. Yes, I've had a couple of times when I've not been able to sing, but it's, been laryngitis or something, like it's not, and I pride myself on, trying to keep quite healthy and all those things, but I'm not particularly strung up on things. But I went to do this big Strauss spectacular for Scottish Opera and got up there, and it was a very short rehearsal period. And the last time that I'd sung for Scottish Opera, I had to cancel. And it's one of the only times, I think there's 3 times in my whole career I've had to do that. And so it's haunted me. And again, I'm not someone who gets in my own head very much, but we had the first rehearsal, everything was going well. And towards the end of the first rehearsal, I thought, something's not right. And by that night, I had nothing. Like I did, and I thought, oh my God, like this is weird. Like and it wasn't fatigue, it wasn't anything. And I just got my own. Anyway, so they sent me to see Scottish Opera had their guy that they sent me over to see. And it was the first time that I'd had, something like that done. So when you say about singers feeling a bit anxious about it, it's really funny because I would never have been nervous about seeing that before. But given psychologically the fact that I'd cancelled previously, that I only had a week while I was up there, it was a very fast turnaround. I'd spent months learning this Strauss because it was a bitch to learn. And I thought, oh my God, I can't have done all this work. And come on, again, I was like, I'm only human, but still this is weird. Like I didn't feel ill, like the whole thing. And when I got the scope, it's like, yeah, everything's fine. Like I can see that you've had, there has been a little bit of swelling, but nothing, unusual. Your cords are actually really healthy. And part of me was just like disappointed that there wasn't anything obvious that I could fix. It was like, and then it then you get that game of, is it in my head? Like what the hell? Like Helena, this is not normal for me. And then I like, now, a year later or so, I look at it and I'm like, Helena, that was wonderful. Like your cords are healthy and it was a good, and okay, maybe there was something a bit that had been there. But yeah, I was disappointed that there wasn't something like remarkably obvious that I could have an instant fix for,
Yeah, it's interesting. I do get that reaction sometimes. I mean, in the vast majority of cases when a singer has their vocal cords examined and everything's okay, there's a sense of relief and people kind of skip out of the room. But occasionally, and actually it's interesting, particularly when people have had a problem with their voice for a long time, they sort of want there to be, as you say, something fixable, a surgical solution or a medicine that's going to make it go away. Did the Strauss go okay in the end then?
It did. I mean, they gave me some steroids and they said, see, hey, and I said, look, I'd really prefer not to take them because I've never done it before. It's not something I've had practice with or that I know.
Yeah.
And I'm a control freak with my voice. So I, want to, be in full understanding of, everything. So very fortunately I was fine. And I think you're right. I think in a way I went as well, like there was a part of me that just was like, okay, I'm really glad there's nothing physiologically wrong, meaning I can go forth and sing, like just give myself, 24 hours, take it easy at the orchestral. And then it was a triumph, thankfully. Then I also felt a bit embarrassed that it was the first time I'd ever been to see my babies my whole life. So I definitely, it's on my hit list of things to do when I'm in good shape to go and, get a scope, when I'm in the good headspace about it too, and actually seeing things.
Well, if there's no need to be seen, and if you aren't having specific problems, then that's great. Carry on as you are. You're very fortunate to have got that far without needing it.
I think so too.
So,
yeah.
With that, Declan, and not specifically about your situation, Helena, but how often do you see the difference between something that's psychological and physiological when you're dealing with some vocal issues?
I think, so the frequency with which I see a lump or a bump or a bleed or something visible on the vocal cords, I guess is maybe one time in 5 or something like that when I'm examining a larynx. That's not to say that all of the rest are psychological, because there are often sort of technical things about posture or about demands of a particular show or about breath support or how recently have you seen a singing teacher. So there's a whole bunch of issues
and reflux
there
too, right? That's a bit of a
yeah, reflux. Yeah, we can chat about reflux. Yeah, absolutely. But I think it's almost always the case that there are psychological issues for every singer. That it's not whether you have something physical there
right.
or not. Everybody gets in their own head from time to time,
Sure.
and everybody knows about particular trigger points for them with certain vocal things. So as the years have gone by, I've increasingly been opening up conversations with patients about how much the psychological aspects of their voice are having an impact on how they work physically. It might not be the primary driver for why they're having a problem with their voice, but just be open to the idea that the psychological aspects of this might be feeding into it.
And if you were chatting to a group of, say, young artists, like you said, you go in and have a chat to people about vocal health and everything, what are the first aspects that you would say? What would be the first kind of little trigger warning that someone as a singer could maybe think, it might be something other than just an infection? What would you say?
Yeah, I think one of the things that happens when you have small swellings on the vocal cords, on the inner edges of the vocal cords, is you tend initially to start losing the top end of the voice. So somebody who is having problems, particularly in their sort of floated upper registers, dropping in on a top A piano sort of thing,
that's
not
my
working.
Thing. My wanky high
Right.
notes, yeah.
Yeah. So if that starts to cause problems, then that suggests that maybe there is something going on the medial edge of one of the vocal cords. But I also think it's worth people just trying to work things through over the space of a week or two. I wouldn't want people to get too trigger happy and think, look, I've had 2 days of my top A is not working and I need to go and see somebody.
But on a long term, more long term.
On the long term, yeah. So if there's something that's been going on for several weeks, then it's certainly worth getting it checked out. And also, as you say, with your Strauss thing, if you've got a big gig coming up in a week's time and there's a problem and you need to just know what's what and whether you can go ahead, then that would be a good reason to come and see someone.
And what about when a voice starts to get quite a lot like excess air to the sound of it, and like a breathy quality when it doesn't usually have? What could that be?
That's usually a technical thing, and that's usually to do with a small gap at the back of the vocal cords on phonation. And there are generally sort of technical fixes that can be worked on with that. It's quite with female larynxes, it's quite common for there to be a little bit of a gap at the back. When does that become a sort of problem? I guess it becomes a problem when the voice is excessively breathy. Yeah, and very often working the voice in different ways will give better closure. Different vowel sounds, different degrees of brightness will change that closure.
Gosh.
So tell us about reflux then, because I'm really interested in that. And I know certainly at the start of my singing career, that's actually the first reason that I went to see an ENT was because I was concerned about reflux and performing with that. And so tell us about that.
Well, reflux is a fairly controversial topic, I think it's fair to say. The background of our understanding and our discussions about reflux really go back about 20 years. There was an ENT surgeon in the States called Jamie Kaufman who started linking vocal problems and throat problems with reflux. Now, that unfortunately led to a proliferation in the prescription of PPI medications. So things like lansoprazole and pantoprazole and omeprazole and esomeprazole and this whole bunch of medications and they fundamentally reduce the amount of acid that the stomach is producing. And that has, without question, led to an overprescription of those PPI medications.
Right.
Now, there are some people who have heartburn and have raging taste of acid in the back of the throat and, absolutely barn door, clearly got reflux, and a PPI in those situations is very helpful. But I think if you're a singer who is having subtle problems with certain parts of your range, if there's a bit of excess mucus, if there's some vocal fatigue, and if there's a suggestion of maybe a little bit of redness around the back of the larynx, well, that suggests that there may be some reflux, but it might be subtle.
Yep.
And I am very much of the school of thought that would try to avoid the prescription of PPI medication at the first visit. I'm open to the idea of prescribing it if things aren't settling down, but in the first instance, there are very helpful non-pharmacological ways of managing reflux.
Cutting out certain
for you
foods.
guys, right, exactly. Avoiding spicy food, avoiding fizzy drink, avoiding eating late at night. The trouble is that all of these things, all of the things I've just described, are things that typically happen when you're a singer. You do a show, you go and have a beer, and a curry after the show, and then you go straight to bed. So trying to break those habits is quite difficult, but I think singers are much more alert to those issues and how to manage them than they used to be. If those sorts of things aren't working, if there's a suspicion of reflux, then I will prescribe a PPI. And then beyond that, if the PPI isn't helping, then there are reflux tests that can be done. I don't do the detailed reflux testing myself, but I work with a gastroenterologist who does dual probe pH monitoring. So he'll put a tube in the nose that sits in the stomach for 24 hours. And there's an acidity monitor down just above the stomach to see if any reflux gets out of the stomach. There's an acidity probe right up at the top of the throat as well to see how much acidity gets actually up there. And then you can properly, definably quantify how much reflux there is. Because it may be that there are other reasons for the voice to be problematic that aren't reflux, and then you can kind of absolutely confirm or refute that.
Yeah.
The reflux, we've had quite a reevaluation of reflux over the last few years. There was apart from the sort of singers I see, I spend quite a lot of my time seeing patients who are being referred in by their doctors with possible throat cancer. So I do these, we call them 2-week wait clinics, because we have to see them within a fortnight to establish what's going on. And quite a lot of patients in that situation have fairly sort of non-specific throat symptoms. They have a kind of feeling of a throat in the lump, or they're clearing their throat a lot, or a bit of discomfort and what have you. And almost always that's not cancer. But the GPs historically, over the last few years, have got into the habit of prescribing PPIs just to see if it is the reflux that's an issue. And the problem is that when you're on a PPI, it then becomes very difficult to come off the PPI. And there have been some studies recently that have said that throat symptoms, if you prescribe a PPI or if you prescribe a placebo for sort of general throat symptoms, there's no difference between the two. So we really are very much moving away from prescribing the PPIs if we can avoid it.
My mother is 83 now, and a couple of years ago she started this kind of real issue with throat, and she's definitely not a singer, I would like to say. She's very far off it. I had to take her for a scope, and my mother's got a wicked sense of humour. There's a lot of fun. And they said to her, they were talking about reflux, and there was all this kind of like clear bubbles and stuff that was coming up her throat, and she feels very much like she can't breathe sometimes, like it gets all stuck, and she's got this horrendous like kind of cough thing that she does where it's just kind of this frothy stuff at the back of her throat. Anyway, they said to her, we've got to rule out kind of reflux and talk about your eating habits. My mother is I don't know if there's an actual word for it, but she's addicted to tea, right? Like that's like she's a teaaholic basically, and which is kind of funny. And they said to her, do you drink a lot of caffeine? And and she's sitting there, she's like, no. And I just looked at her and I went, what about tea? And she's like, well, yeah, I mean, it has a little bit in it. And I was like, Mum, it's still caffeine. And she's like, and they're like, how much tea do you drink, Norma? And she's, a few cups a day. And I'm looking at her, I'm like literally my mother would drink 20 cups to 30 cups a day. And she drinks it.
Oh my God.
Yeah. And she's got really bad sleeping habits. So she'll be up until 2 a.m. and she'll still be drinking tea, and then she'll just go to bed. And so they said, do you drink tea like late into the night? She's like, Well, and I'm like, can you stop like blatantly lying, And the guy said to her, I think you need to try to look at decaf tea, for the evening. And she's like, no. Like just straight up, just told him no. And then he says to her, what about your eating habits? Do you again, it'll be like midnight, 1:00 in the morning, and she'll go and get a snack or something and what do you eat? And my mum I should tell you, she used to run restaurants. She's an amazing cook, right? Like amazing. That's what she's known for. And he said to her, so after dinner, I'd like you to have some Gaviscon or something like that. And she said, well, you can tell me that if you like, but to be honest with you, I'm not going to do it. And the guy was like, the poor man, I was so embarrassed. And I said, well, I was confused. I said, why? She said, do you know how good my food tastes? She's like, do you know how bad Gaviscon tastes? She said, I am not putting that in there after I've just had a magnificent meal. I don't want to ruin the taste of the food that I've just, like literally at every corner she was fighting them.
But you know what? That's fine. And if she, I quite frequently see patients like that. And I say, if you, what I hear what you say, and if I've given you some advice, and if you don't want to take the advice, that's fine.
It's
and
like
if all you wanted out of today, right, and if all you wanted to know from today is that you haven't got cancer, then I'm very happy to give you that reassurance. If you actually actively would like to try to help with this, then these are my suggestions. But look, if you'd rather carry on as you are with your current situation, go for it.
Knock yourself out.
No harm done.
Well, I actually had to trick her into like, I got some English breakfast decaf tea, and I tricked her. So I'd make the tea and give it to her later in the night when I was staying there on a contract. And for maybe 3-4 days, like she didn't say anything. And then after the 4th day, she went, just so you know, like I know what you're doing. And I was like, damn it. And she said to me, but I have to admit, Helena, it wasn't quite as bad as I thought it was going to be. So I will try and at least do that. She sounds like an absolute character.
She
is an absolute character. But it was just so funny. Like she was just so straight up. I'm like, Mum, this issue means that she publicly doesn't actually feel comfortable going out sometimes, like watching a show or something, because she actually gets quite built up and she gets quite embarrassed if she coughs like that. But she just, the way she just
I think there is
back to the doctor,
I see quite a lot of older patients in similar situations who have a kind of accumulation of mucus in their throat and are clearing their throat quite frequently. I think there is a thing about age. Your mother's 80-something. I quite often see older patients who have weakness of their vocal cords, presbyphonia. And there is also a parallel thing of presbyphagia, weakness of swallowing due to aging and the muscles just not
she's got similar. It's all very, it just does, the muscle just doesn't.
And so she's just not clearing things as efficiently as they used to. People, I think, sometimes think that it might be that there's an accumulation or they've got too much mucus, but I actually think it's the opposite way around. I think it's just that they're not clearing it efficiently because the muscles have aged a bit.
And talking about getting older and the changes that you see, what's the difference between like looking at, say, strength versus endurance as a singer gets older and wanting to work on strength of the muscle versus, say, endurance of the muscle? I mean, have you got any recommendations for those kind of things as we age as singers? I mean, I guess already we're doing good things anyway in using everything, like, continuing on.
Yes, I think I was just about to say it's the use it or lose it thing, I think, is important. There aren't any sort of physical changes that I see in the larynx. It's very subtle. And I think there's a thought sometimes that we talked already about people thinking that maybe I will be able to determine what voice type they are based on how the vocal cords look, or, various other things. And equally, there's subtle changes that happen to the voice as you go through your 20s and 30s and beyond are too subtle for me to be able to see on a scope.
And of course, caused by different things too. It's not just like a physiological change here. It's hormonal. It's
hormonal. Yeah, it's to do with support systems, and we haven't talked about the strap muscles and the muscles that sort of anchor the larynx as well. So seeing those changes physically on the vocal cords is generally not something that's achievable. How did we get onto that? We were talking about aging voice, right? Or
aging,
voice changes, as voices mature. Yeah.
I was just going to say, Declan, during COVID, I know you took quite a big kind of step, like to help people and things through COVID and coming forward. Have you seen any kind of big changes coming out of that? I mean, I I got COVID quite early, and I was hospitalised and told that I would never sing again. And
Wow.
I had a PPI that was massive, and they actually said to me, my team in at Royal Surrey said they feel like if it wasn't for my singing, I probably maybe wouldn't have made it through, in the sense of the size of the PPI and how I managed to actually, keep on breathing.
So Helena, PPI?
The clots to my lung.
A PE, you mean?
Oh, sorry,
PE.
PE. Yes, sorry.
Pulmonary
I thought I was being
embolism.
all clever
Right.
then.
Yeah.
Obviously not.
Oh, gosh,
Sopranos should
okay.
never try and do that.
So
it was.
Oh, gosh, okay.
It was really early, and
Wow.
I basically had COVID, and then just couldn't breathe one day, and went in and the rest of it. And it took quite a long time to recover and to build. And the doctors had said to my other half, there's a good chance that, given the size of that clot, there's a really fantastic chance she won't be singing again, and she has to work that through. And on day one, I was at the piano and looking defiantly at my husband, who said, "Babe, remember what?" And I said, "No one tells me. No, that's just not going to happen." So yeah, just coming out of COVID, are you saying any major changes coming out of that long term?
Well, I mean, COVID was very interesting. We can chat about sort of aerosols and transmission maybe in a minute, but in terms of the long-term changes for singers, I'm seeing relatively little. Thankfully, I'm seeing relatively little now. Where are we in January 2026? At the time, we were seeing some very weird things. We saw some really quite major laryngeal pathology, not just in singers, but in all comers. Abscesses and swelling and granulomas and bleeds and narrowings and stenoses and all sorts of really odd stuff. That kind of that immediate phase thankfully settled down. And obviously singing then stopped for quite a long time. There were no shows open, there were very few concerts happening, and people, I think, were practicing in a different way. So when performances started up again, I guess in the middle to second half of 2020, I did see quite a lot of people who just basically hadn't really done very much practice, and when they got back into it were thinking, hang on a minute, this feels really odd. I'm not sure whether there's a problem or whether actually it's just that I haven't been
on the bike for a while.
Over.
Yeah.
Right, exactly. So there was quite a lot of that. We're seeing quite a lot of post-COVID patients and post-flu patients now, particularly, it's winter here in the UK at the moment, and I'm seeing quite a lot of post-flu patients. But actually, the COVID and flu type symptoms are relatively indistinguishable. We've had a horrible wave of flu here in the UK, and I'm seeing patients, whether it's COVID or flu, I'm seeing quite a lot of people who have quite a long recovery phase after having had that sort of viral infection. And, there's no magic solution for that, unfortunately. Just riding it out and getting the voice to work as well as you can. But thankfully, I mean, there is obviously that really very unfortunate cohort of long COVID patients who have fatigue and respiratory issues and memory issues and all the sort of stuff that goes with that. But I am seeing fewer of those as time goes on, thankfully. And the singers, by and large, I would say, have come out of it and, got back on.
That's fantastic. Well, you were really, as you mentioned earlier, really involved in the research around that COVID time, and you were quite instrumental in getting a lot of the performance spaces and rehearsal spaces opened up, weren't you? Can you tell us a bit about that?
Yeah, I mean, it seems like a lifetime ago now. It's nearly 6 years ago. But at the beginning of the pandemic, there were these clusters of COVID centred around choirs, or seemingly centred around choirs.
Oh yeah, of course.
There was a thought, therefore, that COVID was more readily spread in people who were singing, and as a result, the knee-jerk reaction from governments was just to say, right, in that case, no singing, no performance, no choir rehearsals, no nothing. And I took calls from a number of friends who are choral directors and musicians saying, well, how exactly we're going to get out of this? I mean, I was just a jobbing ENT surgeon at that stage. I have absolutely no research pedigree, but it was clear that something was going to have to be done to get some data about how much of a problem singing was compared to other activities. And around that time, I met a professor of aerosol science from Bristol, and I met a guy who kind of does government work, and we ended up getting involved with some of the UK government
That's
projects.
Right, I remember that.
So
now,
a number of things kind of coalesced, and we set up this research project where we measured the amount of aerosol coming out of people's mouths when they were singing, when they were speaking, when they were coughing, when they were doing speech therapy exercises. We then went on to do woodwind and brass instruments, and we looked at children and adults and exercise. We did a whole bunch of research experiments that had never really been done before. And the upshot was that although singing produced a bit more aerosol than speaking, it didn't produce vastly more. So, and it's actually it's the phonation, it's the production of sound that causes the problem, and it's the volume, the amplitude with which you're speaking or singing that is the primary problem. It's not so much the actual fact of singing. And intuitively, we know that because singing isn't so different from speaking. You're just manipulating your vocal tract in a different way. There isn't any inherently very different thing about it. But the governments were very clear that they weren't going to allow singing to happen again until we had got some concrete data on it. Yeah, and we were feeding through our results sort of in real time to the Department of Culture, Media and Sport here in the UK, and they were kind of almost watching the results come through in real time, and then in the middle of 2020, they decided to start opening up performance again.
Amazing. God, thank you for that. Gee.
All right. And it was a huge team that did it.
Yeah.
Because I had that kind of
fascinating
1 foot in each camp of the science and the singing, I sort of ended up being the person who people were talking to about it. But there were a dozen or more people involved in the research.
Is there anything in your career that you've seen, that you've been presented with, like a scope or anything that's been incredibly unusual? Like something where you've actually had to do a double take and try and be professional and not react by either, I don't know, vomiting or skipping for joy or like. Well, I say that because when I went through all this stuff that I told you about, I go back into emergency the week later because I ended up developing a really bad infection, and one of the guys said to me, "Can I just tell you, we've got your X-ray up on the wall as a survivor, because of what you went through." He said, "The size of that clot," he said, "oh, I'm not going to lie," he said, "it made me want to vomit a little bit, but I'm like so proud of you." And I was just like, what the hell? Like, I didn't know whether to like go with the victory or be disgusted by what he'd said. So is there anything that you've ever come across that's made you have a reaction like that?
Yeah, I've got one or two videos of larynxes that I wheel out occasionally just as sort of interesting things. I've got a lady who came as an emergency with a potato in her larynx.
Oh my God.
She was an older lady who was being fed her dinner and partly inhaled this potato that then sat just above the vocal cords, and it was a small enough bit of potato that she could just about get enough air around it so that she could still breathe, but it was big enough that it hadn't actually gone through the vocal cords and into the lungs. So you could see this bit of potato bobbing in and out of her larynx, and she hadn't got the strength to cough it out. So that's quite a good one.
Oh, wow. So what happened there? What happened in the end?
Yeah, I mean, basically, we in the emergency department gave her, or not we, my anaesthetic colleagues gave her some drugs to drift her off to sleep for a minute and a half, and we tipped her head down. We got the trolley tilting right so that she was at 30, 45 degrees head down. I looked in her mouth and got a pair of forceps and just hoiked the thing out, and then we woke her up and it was fine. So that was quite fun. So the potato in the larynx is one for the trophy cabinet for sure.
That is something. I'm going to feel nervous eating potato next time, but yeah.
I think maybe I've lost perspective on what weird or gross or excessive is. I see big tumours, I see papillomas are these crops of warts that sit on the vocal cords, and I see kind of quite extensive things. But I think having seen so much of it over the years, I've slightly lost the oh wow fact. I mean, a potato in the larynx I think is quite
I was going to say that wins. Yeah.
But the pathology is just about sort of degrees of severity, and I lose the oh yuck factor. But I do, in these talks I do for young singers and conservatoires and things, I do show pathology that singers develop, but I also show some of the other pathology I see, and this papilloma thing, these crops of warts, unless you have seen it a few times before, there is a slightly ooh yuck factor about it, and I sort of the people cringe and hide behind their coffee cups when I get those videos out. It's just slightly weird. As I say, I think I've lost perspective on what gross is.
Look, we're coming close to the end of our chat today, but I did, just before we wrap up, I did want to ask: is there any general advice that you'd give for singers, young singers, or even mid-stage, late-stage career singers from your perspective?
Yeah, I think there are some fairly obvious basic things, just in terms of looking after your voice, hydration, avoiding caffeine, and managing reflux, and those sorts of things that people will be doing. It surprises me still that some singers smoke, because that is, just as far as I can see, is completely incompatible with a career in singing. And if they are singing now, they won't be singing in 10 years' time, sort of thing. Avoid thinking about the totality of vocal loading, by which I mean, you might be practicing for a couple of hours a day, and that's a reasonable amount of pressure to be putting on your voice. But if you're also going out to pubs and nightclubs 4 nights a week, that's more of a problem than the actual singing itself. So, and I think that's a particular problem for young singers who are in conservatoires. They want to be able to have a good time. They want to be able to go out.
I learned that the hard way, definitely. I definitely, because I've never been someone I'm a complete nerd about my voice from a very young age, like always taking care. I don't drink, I don't smoke, the whole caboodle, but I love to have a night, I love to have fun. And I remember, I went to my first nightclub when I turned 18, and they had like a Grease mega mix on the thing. And of course, I have to sing louder than everyone, like when we're dancing. And I was doing all the, I got chills, came out the next day, and I was like, and I was like, okay, right, that's never happening again. So yeah, so I hear you on the.
Well, and you learned your lesson the hard way, but some people learn the lesson by going an even harder way and actually causing pathology and then needing to have surgery and what have you. So that's not ideal. So yeah, just balancing how you're using your voice outside of the singing domain and whilst singing as well. And we were saying earlier on about being open to the idea of seeing an ENT surgeon if you need to. Don't be frightened of the process. If you are going to see an ENT, take a video of your vocal cords. It's dead easy just to use your phone to take a video of the screen so that you've got it with you at all times.
I wish I'd done that now.
If you run into problems in future, then you've got that kind of baseline record. And when I'm seeing patients, I always, in my private practice, I always include a photograph of the larynx so that the patient's got it for their own records. Be open to the sort of psychological aspects of problems that can be caused when you're getting sort of slightly in your own head, and think of working with performance coaches if you need to. Touch base with a singing teacher regularly. It's surprising how often people have careers in singing but are a little bit surprised when one of my suggestions is, and I think you should probably go back to a singing teacher because you haven't seen somebody for 5 years.
Yep. Yeah, absolutely. Yeah. I mean, I had a vocal thing. It wasn't a vocal problem. It was just a vocal thing that I needed, to do more work on. And I did that. I went back and went to a specialist in New York when I was over there, and I wasn't shy in asking my colleagues and to get different advice, and you can learn things all the time and every day. And it must be so
Absolutely.
wonderful for all the people that come to see you. Not only are you Declan Costello, like a rock star to the singers, but also like the fact that you have this singing background and this empathy and this understanding as well is just like such a double credit to your bow. I know it's not necessary, but it is wonderful, I think. And I think singers would feel great about that too,
I agree. And I think it is one of the things that I feel very fortunate about is the ability to have fairly nuanced discussions about repertoire and about voice types and about rehearsal schedules and recording and those sorts of things that I think a laryngologist who hasn't got a background as a singer might not have quite such an understanding of. Yeah, I think that's absolutely right.
That's why they're lining up around the corner for you.
That's it.
Bless you. Well, there we go. It's been a relatively healthy winter season over here in the UK, I have to say. It's been reasonably busy, but I think people are looking after themselves.
That's great. Good. No, and there was some great advice there. But now we are coming to the end of our chat, and so we're going to throw you 5 rapid fire questions, and these are new rapid fire questions from
new for 26.
Our first That's right. Yeah, 2025
Should I
questions.
be nervous?
Have
Are
gone.
these going to be awkward?
Definitely.
Yes,
You should
absolutely.
definitely be nervous. Helena, do you want to kick us off?
Yeah. Okay. Declan, what is your go-to karaoke song?
Blue Moon.
Great choice. Excellent. Oh, we like that.
Bit of
Okay.
crooning. Excellent.
Yeah. Question number 2. What will the title of your autobiography be?
Using my voice.
That's good. That's fantastic. Oh, I like that. Yep. That's a good autobiography title.
I should have, well, if I'd been given the opportunity, I would have thought these through and I'd have come up with something clever. But okay, using my
No, we don't want clever.
Yeah, okay,
we
I'll
just
go
want
with
the
that for now.
instant. We just want the instant
that's
reaction.
very good.
Yeah. That's the whole point.
All right.
If you had to give a TED talk with no notice, what could you give a lecture on for 10 minutes with no preparation outside of your obvious field?
What could I give a TED talk on? Raising a child with Down syndrome.
Fantastic.
My daughter has Downs. The thought processes and the surprises and pitfalls and issues around raising a child with Down syndrome.
Oh, that would be an amazing 10 minutes. Oh, I love that.
It would be.
Oh, yeah.
My cousin
Right.
has Down syndrome, and she's one of the most wonderful humans that I've ever met. And what gives me the most pleasure is that every time she sees my brother and we go up there to visit her together, she wants to marry him like every time, and it just gives me so much pleasure because she's so in love with him. Like every time she sees him, and it's just so gorgeous.
Well, our daughter Rosie's 21, and she's got a lovely boyfriend who's 20, and they are very clear that he's got Down syndrome. They're very clear that they're going to get married. They've got the whole thing planned out.
Bless. I love it.
Yeah. No, she's a joy. She's great.
That's fantastic. Okay, question number 4. That's me. What is your most controversial, boring opinion? Okay, so to give you an example, my most controversial, boring opinion might be that there is no wine on earth that tastes as good as apple juice.
Okay, that would be an interesting hill to die on, Adam.
Yeah, this is what I'm saying. A very controversial, yet really boring opinion.
Controversial and boring opinion that choosing the right running shoes is very important.
See, that's fantastic. That's absolutely brilliant. And you say that because I've started to try to run, and maybe that's why I can't run. I'm going to go now and try to find some proper running shoes. Yeah, because that's clearly the problem. It can't be the rest of me. It must be the shoes.
Yeah,
I really like that. That's a very good, controversial, boring opinion.
And our final question on the podcast, where we've decided High Notes and Anecdotes is putting together a crime gang. What skill do you have that we could use to rob the Louvre?
I don't know if it would be of any help, but my wife says that I have an extremely good sense of smell.
Okay.
I'm just trying to...
This could go
I'm trying to work out whether...
That's fantastic.
Is that...
We're including it.
We'll take it.
I think that's it. We have to work out how to use it, but we're going to definitely use it. I like it a lot. That's brilliant.
I could smell my way around in the pitch black.
Done.
If we're doing a
so we knock
high.
out the lights. That's it.
You could tell which part of the building we were in by the smell of, no?
Yeah. Well, when you walk into a music library or into a music room, it's got a very distinctive smell.
You're right.
So you could almost tell which room in the Louvre you're in by the smell.
That's perfect. Yeah,
I love it.
We're locking that in.
We've got our first member of our
in the
gang,
gang.
Adam.
That's brilliant. Okay. Look, Declan, thank you so much for coming and chatting with us today. This was fascinating, so interesting. You do amazing work, and I know so many people around the world who really appreciate it. So thanks for that. And with that, we'll say goodbye and wrap up.
Thanks
It's been a great
Declan.
pleasure. Thank you very much for inviting me, and enjoy your summer. We're sort of trying to enjoy our winter.
We're not going to rub that in at all. Yeah. Okay.
Thank you so much. We're definitely enjoying it. Thanks so much. Take care.
Thank you, guys.
Bye.
All the best. Bye.